Uh, Good evening, everyone. Uh, Good evening, everyone. Today we have the second session on management of carcinoma larynx by faculty Dr. Cessal from CC Trivandrum. So, we'd like to invite you to start the session for now.
Okay, thank you very much for the invitation again. So this is second day of our session. So today we will discuss about the outline in the management. So last time we discussed about the workup, the imaging part, then also a broad outline in the management. Today I will take you through the management, evidence for the management, and if time permits, then we will discuss one session. We will have a short session on the contouring part as well. So I will share the screen. Can you see my slides? Can you see my slides?
Yes, sir. Your slides are visible.
Okay, thank you. Now, first, when we discuss about the management of any head and neck squamous cell carcinoma, the main aim is to have a good locoregional control. Means the aim of treating any head and neck squamous cell carcinoma is to attain a good locoregional control. Means the control at the primary site and also the control at the neck. That means the treatment of the lymph nodes. So when we discuss about the larynx, the aim of the laryngeal management of laryngeal carcinoma up to stage 1 to stage 4A is the aim is to have a cure. In selected stage 4B patients, T4B or N3 disease, we will consider them for radical approach. But in general, any patient up to 70 years and patient is having a performance status 0 or 1, and patient is having a stage 1 to stage 4A, then the intention of treatment is to have a cure. In early disease, the intention is cure and also to reduce the morbidity of treatment, especially in stage 1 and stage 2 disease. In stage 3 disease, the standard is to have good locoregional control and preserve the function of the larynx. In T4 disease, with cartilage destruction, we may not be able to preserve the larynx. We discussed that last time. So we have to consider a total laryngectomy followed by an adjuvant treatment. So wherever possible, up to say stage 4 disease, if the cartilage is intact, then our intention is to have the preserve the organ and also to preserve the function of the larynx. Aim is one cure that we have discussed. So second goal is to preserve the function of the larynx. So function of the larynx means to communicate with a reasonable voice, then swallow without aspiration and breathe without a stoma or a tracheostomy tube. And in early disease, our intention is to reduce the morbidity due to treatment, but that may not be possible in advanced disease. Now moving to the very early disease, T1 or a T2 vocal cord. So what is T1 vocal cord? T1 vocal cord is a lesion which is present only on one vocal cord, that is T1A, or on both vocal cords, it is T1B. But T1 disease should have a fully mobile cord, and there should not be any extension in the supraglottis or subglottis. That is T1. Then there is no size criteria in laryngeal tumors that we discussed yesterday. T2 vocal cord means if there is impaired mobility, number 1. Number 2, the lesion extending in the supraglottis or the lesion extending in the subglottis. That is T2. The anterior commission involvement will not change the staging of the disease. So the implications that we discussed last time, but this will not lead on to the change in the staging of disease. Okay, so now we have a T1 disease. You can see a lesion in the left vocal cord, which is extending into the anterior commissure. I have shown you lesions yesterday also. It's a T1 vocal cord. So in that situation, you should have a CT scan. And also, this is a checklist for before planning and deciding treatment. For why it is T1A or T1B means if it generally in T1B disease, this patient is treated with radiotherapy. Usually they are not considered for laser treatment. In T1A disease, where if the anterior one third of the there is no involvement, there is no anterior commissure involvement, posterior commissure is free. That means a mid-cord lesion. That patient can be considered for radiotherapy or laser treatment. Okay, there is a selection bias for surgical treatment. So it gives equal locoregional control. Okay, that is in T1A mid-cord lesion. In anterior commission involvement, a lesion very close to the anterior 1/3, posterior 1/3, or lesion involving posterior commission, generally they are treated by radiotherapy. So that is why we need to know where is the lesion. That also I discussed yesterday. Where it's in the anterior 1/3, whether it is in the mid-cord, whether it is a posterior 1/3, what about the posterior commissure, what about the anterior commissure? This is very important. Subglottic extension, then it becomes T2. This is treated by radical radiotherapy. Extension to supraglottic larynx, that's a real concern. When you have an extension to supraglottic larynx, then we need to consider that there is a chance for a lymph node involvement. Question is that whether we need to treat them, the lymph nodes need to be treated. Okay, then the mobility of vocal cord. The fully mobile cord, then you say it is T1. If it's impaired mobility, it's T2. When you have a T2 vocal cord, which is due to impaired mobility, our next aim is to rule out we are not dealing with a T3 disease. That's by a CT scan to rule out a paraglottic fat infiltration and ensure that you are dealing with a T2 disease itself. Now that's T1 and T2. If you look into the evidence for radiotherapy versus surgery, all in head and neck squamous cell carcinoma except in carcinoma and nasopharynx, all this early disease can be treated by radiotherapy or surgery. In all the retrospective analysis shows that, okay, it may have good locoregional control with both modalities. There is no randomized data, but I discussed the situations where you will consider only radiotherapy, and I discussed in the situation where you will consider a laser treatment also. So if you look into the Cochrane review, which came initially in 2002 and updated in 2010, which shows that even if you give radiotherapy, then open surgery versus endolaryngeal surgery, that's laser treatment, all have in early laryngeal tumors is having equal locoregional control. That is the Cochrane review. And the basic concept is that any patient who is undergoing laser treatment should not have postoperative radiation. Means you feel that this patient is unlikely to receive post-op radiation, then that patient becomes a candidate. Means generally a mid-cord lesion. But in situations, if you feel that this patient narrow margin followed by post-op radiation is not considered as a standard treatment, but this will lead on to a deterioration in the quality of voice. Now, to conclude, you give external beam radiotherapy or transoral laser microsurgery, or very rarely we do open partial laryngectomy nowadays for vocal cord disease. Main concern is to have good locoregional control with minimum morbidity. It depends on the expertise you have. And if you're planning for radiotherapy, the radiotherapy should receive radiation to the primary tumor. In a T1 and T2 vocal cord lesions, there is no need to treat lymph nodes because chance of lymph node involvement is very low. There is no need to do a prophylactic nodal irradiation in a T1 and T2 disease. So when you have if you're planning a two-dimensional radiotherapy, okay, so the borders will be the anterior 1/3 of the vertebra, and the superior border will be between the caudal edge of the C2 vertebra. So that is the caudal edge of C2, and the cranial edge will be the caudal edge of the C6 vertebra. And if you have you have a subglottic extension, then you need to have another 1.5 centimeter down the CT scan. So you have to, based on the CT finding, you have to take that. Anteriorly, you should flash. A part of the higher epiglottis will not be treated because this is a supra-hyoid part of the epiglottis will not be included in the treatment for a glottic tumor. Generally, this field size will be around 6 into 6 field. And if the patient is having anterior commissure involvement, then you usually use a bolus. Okay, so this is the tumor. It was a T1B disease. Then you have contour that. Then you give a bolus. So that you generally give a wedge also. That's a two-dimensional radiotherapy planning, or you go for a conformal radiation. Now, certain questions. One, whether all patients are candidates for radiotherapy in T1 and T2 vocal cord? Absolutely yes. Whether all patients should have candidates for laser treatment? No. Okay, you should know generally mid-cord lesions are also candidates for laser. It does not mean that laser is the treatment of choice in a mid-cord lesion T1. No, it means it gives equal locoregional control. Okay, prefer radiation because of the quality of voice. Okay, so that is the laser treatment. Then RT should be considered as a reserve. That is another. When you go for the head and neck surgery forums, okay, they always ask the radiation should be reserved as a reserve. No, because in a T1 vocal cord, the 5-year survival or a 10-year survival 5-year survival is more than 90%. So you need not reserve radiotherapy as a reserve. You should not keep radiation as a reserve. Then another concern is that whether RT should be avoided to prevent second malignancy. This is also one question I face when we go for the head and neck surgery meetings. No, it should not be, because wherever it is indicated, we need to consider radiation. So you need to consider the radiation for the patients with T1 vocal cord as well. Now, this is our own results, very recently published in the 3-week hypofraction radiation in early glottic cancer. We, because of the large volume, we usually use a 3-weekly radiotherapy for early glottic cancer, that is T1 and T2 disease. We use a 3.5 gray per fraction over a span of 3 weeks, that is 52.5 gray in 15 fractions. Okay, if you look into the results which we published very recently in eCancer Medical Science, shown that my junior colleague, Dr. Arun Shankar, was the first author for the paper. So this included 329 patients, 329 patients. We are updating the results. We will send this with more than around 450 patients. We are updating the results, and we are drafting the manuscript as of now. And these 329 patients, the T1, the 5-year local control was 94.2%, and T2 it was 84.8%. Included 329 patients, and if you look in the multivariate analysis, it has found that the only factor which affects outcome was whether the patient had a subglottic extension or not. So that is a factor which, if you look at the other series, the larger series come from the Tata Memorial Hospital by Sarbani Madam. It included 652 patients published in 2013, and it showed that again, very good results. Again, the benefit was more in patients who had more than 3 gray per fraction. And so all this is our series, and this all the series have shown that if you give hypofractions, there is a very good locoregional control to the tune of around 85 to 90%. Then coming to the supraglottic tumors, okay, I think there was an overlap, sorry. There's supraglottic larynx. In a T1 and T2 disease, supraglottic larynx can be radiotherapy or surgery. Again, there is no randomized data. But if you have this, we have seen this lesion in the bulky lesion in the epiglottis, and this lesion in the epiglottis and the epiglottic fold. You can see that a pedungulated lesion, early disease. If the patient does not have lymph nodes, usually this T1 and T2 supraglottis. So generally they are treated by radiation or surgery. But the real concern when you consider the treatment for a early supraglottic cancer is that this patient have high chance for a microscopic lymph node involvement, because in the various series in T2 it have shown from 27 to 42%. It shows that there is a high chance for lymph node involvement in supraglottic tumors. So always neck treatment is a real concern, and neck treatment is mandatory in early supraglottic cancer. Suppose if you are planning for surgery, then you have to consider bilateral elective neck dissection, level 2 and 3. That's called a lateral neck dissection or anterolateral neck dissection, in addition to the wide excision of the primary tumor. So again, there is no data. And you can consider radiotherapy to the primary tumor, and also you can consider surgery, equal results, but in most of the centers, it is radiation is preferred. Now coming to the advanced disease, I didn't discuss the T1 and T2 subglottic tumors. T1 and T2 subglottic tumors are treated by radiotherapy alone, and it is very rare. It is to have maybe less than 5%. Most of the subglottic is due to the lesion extending from the glottis to the subglottic area. Coming to the advanced disease, so how I teach my residents is that the carcinoma nasopharynx, so larynx patients can be treated in the 6 groups. One, early disease that we have discussed, stage 1 and stage 2. Second group is patients who have T1 and T2 disease with lymph node involvement. That is mainly supraglottic primer. You usually do not come across lymph node involvement in glottic tumors. So a supraglottic tumor with N1 or N2 disease. So they are generally treated by chemoradiation. The third group is T3 disease, N0 or N2. Then they are generally treated by concurrent chemoradiation. That we will discuss later. T4A is with cartilage destruction and without cartilage destruction. The patient can have extralaryngeal spread through thyroid membrane, cricothyroid membrane. We have seen a lot of T4S extended, lesion extending into trachea is a T4 disease. Lesion extending into thyroid is a T4 disease. Lesion extending esophagus is T4 disease. And larynx extending into extrinsic muscles of the tongue is also T4 disease. they are all approached in a different manner. If a patient is having cartilage destruction, generally they are treated by surgery. It's upfront, you have to consider total laryngectomy and bilateral neck dissection. T4B or N3, so these patients have to be individualized. That we will discuss. In certain situations, we have to consider them for radical approach. If a patient is having young patient, highly motivated patient, low volume disease, low nodal burden, and patients who understand the whole scenario, they are treated with radical intervention. Again, T4B can be with cartilage destruction and without cartilage destruction. That we will come to that. Small percentage can come as a metastatic, because very low, and generally they are treated with palliative. Coming to advanced disease, again, the goal is to have a cure up to stage 4 disease. And those patients who have this lesion is involving the, you can see the lesion in the epiglottis coming to the vallicular. You can also say that vallicular lesion coming to the epiglottis. If it is vallicular coming to epiglottis, it's involving the linguals of the epiglottis, it is T3. I told you yesterday, otherwise if it's a supraglottic tumor, then it is a T2 disease. This is again a T1 bar T2 disease. And any of this with lymph node involvement, then these patients are generally treated by concurrent chemoradiation. Coming to T3 disease. And hemilarynx fixity, this also the repetition of yesterday's slide, because I discussed this slide again. Hemilarynx fixity, post-cricoid. This means these patients are treated by, this is due to endoscopy findings. Now the paraglottic fat involvement, pre-epiglottic space, inner cortex involvement, these all can be made out only in a CT scan. Okay, so this white, this need CT scan, and this can be made out in endoscopy. That is T3. And we will take a case. So this is a 61-year-old male, presents with hoarseness of 4 months duration, performance status 1, comorbidities, no comorbidities. Endoscopic evaluation showed a proliferative growth in left vocal cord. Left vocal cord is fixed. Lesion showed anterior commission involvement. The lesion was extending into supraglottis. Subglottic extension was present. And biopsy showed squamous cell carcinoma. And the X-ray test on outside was normal. Then CT scan showed, okay, we have seen few CT scans yesterday. I will take another situation. You can see, you take at the level of the true vocal cord. I told you how to look for the true vocal cord yesterday. You see the thyroid cartilage, you see the cricoid cartilage, and you see arachnoid cartilage. That's at the level of the true vocal cord. I can see few numbers, more people attending today. And I had a lot of messages yesterday coming that the lecture was scheduled at 7 p.m. Okay, because of, I told them, because of me, it was preponed to 5 p.m. Okay, then, so if you look into the lesion, you can see that this is at the level of the true vocal cord. You can see a lesion in the left vocal cord, the entire left vocal cord extending into the anterior commissure. Okay, that's one. And also you can see the lesion extending into the paraglottic fat at the level of the, this is a false cord. Why you see it is false cord? Because you are seeing arachnoid cartilage. When you see cricoid cartilage, you are at the level of the true vocal cord. When you see arachnoid cartilage, you are at the level of the false vocal cord. Very simple. So here you can see a paraglottic fat. Right side you can see the hypodense area in the right paraglottic area, but that is obliterated on the left side. And also you can see that this again at the level of the false vocal cord. Okay, so the lesion is extending into the supraglottis. False cord involvement is there. And then the patient is having also lesion involving the subglottis. Okay, yesterday again I told you how to look for subglottis. Usually you should not see any soft tissue in the cricoid cartilage. If you see any soft tissue inside the cricoid cartilage, then you have to think that this patient is having a subglottic extension. So this subglottic extension is it means the patient is having a subglottic extension due to the lesion inside the cricoid cartilage. Okay, so then the anterior commission's involvement is there. Always you have to look for erosion of the cartilage. Okay, erosion of the cartilage. Okay, so you have to look, it is not clear. Okay, so it's a T3 because of clinically endoscopically it was hemilarynx was fixed to the paraglottic fat infiltration is there. And so it is a T3 disease. And this patient is having a transglottic tumor because I told you again that the lesion is involving supraglottis and glottis, and again a subglottic extension is present. Okay, so this is a T3 disease. How you will treat the patient? Before the 1991, the publication came in New England Journal of Medicine. All these T3 patients were treated with total laryngectomy followed by post-operative radiotherapy. It's treated by total surgery followed by post-op radiation. That's the standard treatment. But the VA trial, this was a landmark trial, which showed that these patients were randomized, stage 3 and stage 4 patients were randomized to total laryngectomy followed by post-operative radiotherapy, or you give induction chemotherapy 2 cycles, cisplatin 5-fluorouracil. And after 2 cycles, the patients who are given induction chemotherapy were assessed. The patient who responded, that means partial response, were given 1 more cycle of chemotherapy and radiotherapy. There was no concurrent chemo, but the radiation was given. Those patients did not achieve a partial response, 50% regression. They were offered surgery followed by post-operative radiotherapy. And the data was published in New England Journal of Medicine with a median follow-up of 33 months, showed that if you give induction chemotherapy, 2 things. 1, you can preserve the larynx. 2, there is no compromise in locoregional control or disease-free survival. It means if you give neoadjuvant chemotherapy, it can increase organ preservation without compromising the overall survival or disease-free survival. The laryngeal preservation was 64% in patients who received induction chemotherapy, and the 2-year survival was 68% in both arms. Now the question is that, okay, whether it's to go for induction or to go for concurrent chemoradiation. Okay, so there are 2 different approaches happened across the Atlantic. One, after the induction chemo followed by radiotherapy became the standard, and in the Americans, they used the RTOG 9111 trial. It was a 3-arm clinical trial. I will come to that. And in the Europe, they started using, they have used in the VA trial, used cisplatin 5-fluorouracil. Why don't you use a docetaxel in addition to against cisplatin 5-fluorouracil as induction chemotherapy, and whether the 3-drug induction is better than 2-drug induction. So this is a parallel approach. Okay, so I will discuss one by one. The RTOG 9111 clinical trial. RTOG 9111 clinical trial is a landmark trial by the Arlene Forestier and published in New England Journal of Medicine 2003 with the median with the 3-year results in initial. There was an update in ASCO in 2006, and the 10-year result was published in JCO in March 2013. And it included 570 patients. The 3-arm clinical trial. One arm was the experimental arm of the VA trial. That was induction chemotherapy. The responders were given radiation, and non-responders were given surgery followed by radiation. The second arm was what is the impact on concurrent chemoradiation. And third was the radiotherapy alone arm. This is a 3-arm. All 3 non-surgical arms were randomized. This arm did not receive chemotherapy. This received only radiation. So I said initial publication in 2003 and update results in 2013 with 10-year follow-up. And it showed that in initial publication in New England Journal of Medicine showed that those patients who received concurrent chemoradiation had a better locoregional control and laryngeal preservation compared to patients who received induction chemo followed by radiotherapy or radiotherapy alone. And in the updated results, which was present in ASCO 2006, it showed that in those patients who received concurrent chemoradiation, the 5-year laryngeal preservation rate was 83.6%. And the 5-year overall survival was 54.6%. Okay, this is important because, okay, around 55%. That was the 5-year survival of patients who received chemoradiation for stage 3 patients, for stage 3 and stage 4 patients. When they updated the results, it was found that laryngeal preservation and locoregional control were better in patients who received concurrent chemo, but there was no difference in the outcomes in overall survival in patients who received between radiotherapy, induction chemo followed by radiation, or concurrent chemoradiation. Actually, the concurrent chemoradiation had an inferior outcome, but this was not statistically significant. And the explanation which was given was due to the long toxicities due to the chemoradiation. Unexplained toxicities were there. But there was no difference in the overall survival between the 3 arms. So this was the okay. Can you admit the people in this one? Yes, okay, they have been admitted. Okay, yes. Next, this is so the 10-year results showed that RTOG 9111 better local control and or the organ preservation was with the concurrent chemoradiation. No difference in the overall survival between the 3 arms. Now coming to the induction approach, what is the benefit of adding another drug in addition to cisplatin 5-fluorouracil as induction chemotherapy? So again, the control arm was induction chemo followed by radiotherapy with 2 cycles, two drug, that is cisplatin 5-fluorouracil, but the experimental arm was 3 drug regime. There is no concurrent chemoradiation arm in that. This is a GOTAC 2001 clinical trial. It was showed that the patients were randomized between cisplatin 5-fluorouracil versus cisplatin 5-fluorouracil with docetaxel, so DCF regime, and around it included around 200 patients, 210 patients, around 110 patients in one arm, and the TPF arm it was 103 patients. And this data was initially presented in ASCO 2006, and there was a publication came in JNC in 2009, and there was an update in the same journal in 2015. And they was compared to cisplatin 5-fluorouracil versus cisplatin 5-fluorouracil and docetaxel. If you look into the objectives, laryngeal preservation, overall survival, and progression-free survival and toxicity, and when they updated with 10-year for almost the median follow-up of 105 months, it have shown that laryngeal preservation was better with 3 drug compared to 2 drug, but there was no difference in the disease-free survival or overall survival. It means the benefit was mainly seen in laryngeal preservation. But it has to be emphasized that there is no concurrent chemoradiation in this. All these patients received either 2 drug or 3 drug as induction chemotherapy. Now coming to the meta-analysis, okay, meta-analysis, there is a McKenzie meta-analysis, site-wise meta-analysis for larynx and hypopharynx. It was found that if you look in the larynx, it was found that if you give concurrent, the benefit at 5 years was 5.4%. And this was borderline statistical significance. Okay, the benefit was mainly seen, the induction chemo benefit was mainly seen with hypopharynx alone. Now the biggest question is that whether the Americans believed concurrent chemoradiation is superior, Europeans believe that the 3-drug induction is superior to 2-drug induction, and it was not compared with the concurrent chemoradiation. Then came the GOTAC trial. This is evaluating whether the concurrent is better or 3-drug induction followed by reassessment is better. Okay, so to look that, there is an ongoing clinical trial, the GOTAC clinical trial. So the patients were randomized. You give concurrent chemoradiation plus bar minus salvage surgery. That's the experimental arm. Control arm is you give 3 cycles of cisplatin 5-fluorouracil and docetaxel. Then you reassess. There is 50% regression. There is you do surgery followed by post-op radiation. And those patients who have good response were offered a organ preservation approach with radiotherapy. So it's an ongoing clinical trial. So the standard treatment is you can consider it as concurrent chemoradiation based on the RTOG 9111 clinical trial. And there are certain situations you have to consider induction chemotherapy. If you have a very advanced disease where there is an airway compromise. Yesterday also I discussed that point, that if the patient is having a very advanced disease, although the cartilage is intact, if you start the patient on a concurrent chemoradiation, definitely this will end up in a tracheostomy. So if the patient is having mild stridor or the patient is having airway compromise is there, you admit the patient, then you give the cisplatin, the induction chemotherapy of your choice, then you reassess during the next cycle of chemotherapy. And if there is no airway compromise, then you proceed with your chemoradiation. And in certain situations, where if there is a delay in date for starting radiation or a very heavy nodal disease, N3 disease, then you may have to use induction chemotherapy. Yes, then this situation, this we discussed yesterday, but I will take for a situation where the patient is not having good performance status. Okay, so if a patient is having standard treatment is to give concurrent chemoradiation is the standard. If the patient is having a cisplatin cannot be given, either due to the renal impairment or due to the ototoxicity or the poor performance status, especially less than 70 years, if the options you have is to consider, one is to consider you can consider carboplatin, you can have low dose docetaxel based on the new TMS data, or you can consider a the cetuximab. These are the options you have. And above 70 years, the McKenzie meta-analysis have shown that chemotherapy have a negative impact, and there is an increase in 120-day mortality. And generally, the chemo is discouraged after 70 years, or patients who have this performance status 2 or more. Means it may be wise to avoid chemotherapy in them. And these patients may be offered a radical radiotherapy or planning for radical approach. Now, coming to the, if you are interested, you can read this review article. So this a current status of organ preservation carcinoma larynx. This was published in 2018. Okay, you can say that it was almost 5 years back, but still it is valid because there is no much progress has occurred in the organ preservation of larynx. So this was published in World Journal of Oncology. You can search in the PubMed. Okay. Now coming to our own results in chemoradiation, again, we published recently in the molecular clinical oncology, and it showed, and we had the number of patients included 630 patients. Majority of the patients were stage 3 patients. So patients received the chemo or organ preservation approach. Either you give concurrent chemoradiation, induction chemo followed by radiotherapy, or induction chemo followed by chemoradiation, or radiation alone were included in this analysis. 630 patients, majority of the patients were stage 3 patients, 367 patients, around 60%. And that is stage 4A is around 240. This stage 4 is because of the nodal disease, and it's not due to T4 disease. And again, the stage 4B is mainly because of the nodal disease, a small number of patients. Majority of the patients received, substantial number of patients received concurrent chemoradiation, around 47%. Others include induction chemo followed by chemoradiation, induction chemo followed by radiotherapy. These were mainly, this included the patients from 2005 to 2015, 10 year. At that time, there were waiting period. That was the reason why many patients received induction chemo. Then radiation was given, alone was given in patients, 177 patients. That's around 28 patients because of the poor general condition or patients above 70 years. If you look at a median follow-up of, you can see that the results at median follow-up 58 months, it has shown that the 5-year overall survival for stage 3 patients were 58.9%. Stage 4, it is 34.9%. This is a huge dip when patients became stage 4A compared to stage 3. And stage 4B, it was 34%, 30.4% at 5 years. And same is more or less with the disease-free survival. It was better in patients with stage 3 patients. Disease-free survival was 56.3%. And the around 89%, if my memory is correct, 89% of the patients attained clinical remission with the chemoradiation or radical radiotherapy alone. But the other patients who did not receive, only 11% underwent salvage surgery, because either because of the general condition, poor general condition, or the patients had willing to undergo surgery. So many issues were there. Okay. Now, if you look into the guidelines of advanced disease, you can see that this is the ASCO recommendation that published last in 2018. I need to attend a call, to be very honest. This is from my Wi-Fi. Okay, emergency. Okay, give me. Wife is always the boss. Okay. So coming to the guidelines, the NCCN guidelines 2023, this is the latest guidelines which published online on December 20th. If you look into the glottic tumors, T3, or for supraglottic tumors, the standard treatment is to consider, this is a standard treatment is to go for concurrent chemoradiation, or you can consider surgery if generally if there is a dysfunction of the larynx. Otherwise, always try to have an organ preservation, or you give induction chemotherapy. So the first approach is to give concurrent chemoradiation in T3 disease. That's applicable for glottis as well as supraglottic. There is separate guidelines. I told you yesterday, there's a separate guideline for glottic and supraglottic tumors. Now coming to the Coming to the patients with T4 disease, never consider them for a radical chemoradiation. All these patients with extralaryngeal spread, thyroid cartilage destruction, all these patients should undergo a surgery followed by postoperative radiotherapy. So it should be a planned treatment, and patients should have enough reserve to undergo surgery followed by post-op radiation. When you look for CT scans of all these patients, you have to look for where this is how you look for. You compare with the other side, you can see an extralaryngeal spread, soft tissue outside the larynx framework. It's extralaryngeal spread. You can see here, you can see here. So it means this patient is having extralaryngeal spread through and through cartilage. And this patient should undergo a primary surgical management. When the extent of skin involvement, if the skin is involved, then you have to look for, because this is required to, this is how you decide, how they decide for the flap for reconstruction. Always you have to look for the thyroid gland is intact or not. What about the carotids? What about the prevertebral fascia? The extent of extralaryngeal spread. These are real concerns when you look for a CT scan or advanced laryngeal tumors. This also I mentioned, there was a query yesterday, why these patients with T4 were offered surgery and not chemoradiation. This is a subset analysis of the VA trial, which showed that those patients had more than T4 disease, less than T4 disease. The 5-year, the laryngeal salvage surgery rates were 28%, but it was almost double in patients with T4 disease, and this was quite statistically significant. So that's one of the reasons why all these patients were offered surgery. But in a T4 disease, if the patient is due to a extralaryngeal spread, but the cartilage is intact, due to a cricothyroid membrane or due to a thyrohyoid membrane, always you can consider them for a chemoradiation program. Yes, in patients with T4A, the standard treatment is to go for surgery followed by postoperative radiotherapy. In T4B disease, either due to the prevertebral fascia involvement, encasement of the carotid artery, or due to the mediastinal involvement, they are generally treated by surgery. They are treated by palliative treatment, because very advanced disease patients should not be subjected them for radical approach. Here you can see a very extensive disease, skin involvement, prevertebral fascia involvement, extending into all the way to base of tongue, and also the epiglottis is involved, subglottic extension. It is a very difficult tracheostomy, and it may be very difficult to treat them with a radical intent. Generally, a concern for palliation. Again, in advanced, very advanced nodal disease. Okay, again, nodal disease is a heterogeneous disease. The patient is having a small primary, like a T2 primary, supraglottic larynx with a 6.5 into 6.5 centimeter node. T2N3, generally they are treated by chemoradiation, plus bar minus salvage neck dissection if there is a residual disease in the neck. But in patients with a advanced primary, skin with a node with extensive skin involvement, ulcerated node, and it is a heterogeneous disease. N3 disease itself is a heterogeneous disease. A minimal skin involvement can be there, but the patient is a frank ulceration can be there. A large node extending from level 3, level 4, so up to the root of the neck with a very large ulcerated skin. But they are all treated by palliation. But selection should be there for considering them for a radical approach. So T4B bar N3 is selected in good, highly selected patients with good performance status, relatively young patient, low volume disease, absence of heavy nodes, good social support, highly motivated patient, and patient who can understand the situation. They are treated with radical intent. The patient is having cartilage intact, then you can consider for a radical chemoradiation. The patient is a cartilage is involved, intact, you consider them for chemoradiation. There's cartilage involvement, then generally, and the T4B is because of the prevertebral fascia involvement. Then you give induction chemotherapy, then you reassess, then subject the patient for total laryngectomy followed by postoperative radiation. If there is a poor response with induction chemotherapy and the prevertebral fascia is again involved after sufficient cycles of induction chemotherapy, then it may not be wise to treat them with a radical intent. So coming to the conclusions of the advanced disease, T1 and T2 with a nodal involvement, that is mainly supraglottic tumors, they are treated by concurrent chemoradiation. T3 and 0 to N2, and if there is no dysfunction, no aspiration in fluoroscopy, then generally they are treated by concurrent chemoradiation. That's concurrent chemoradiation. T4A without cartilage destruction or dysfunction means thyroid membrane or cricothyroid membrane is involved, extralaryngeal spread, but the cartilage is intact. Then you can consider them for radical chemoradiation. But the proper interaction with your radiologist is required, because to rule out a through and through cartilage in this group of patients. With patient with a T4A disease with cartilage destruction, this may be the only upfront indication for doing a surgery in CA larynx. Okay, if I say in a surgery platform, definitely they will not call me next time for any program, because okay, this may be the truth. Okay, in any patient with a cartilage destruction, this patient should undergo surgery. Total laryngectomy, bilateral neck dissection, then reconstruction if required, followed by planned post-operative radiotherapy. T4B and N3 disease, the selection is required in patients who are planned for radical approach. Okay, now coming to this, I will take a case. So can I take another 10 minutes? Is it okay? Can I? Hello? Can
Yes, sir.
Yeah, okay, yeah. So I will take a case. Okay, this is a supraglottic tumor, which is involving, there is no lymph nodes. Actually, it was involving. So again, we will revise the imaging we discussed last time. Okay, so this is a supraglottic disease. It was a supraglottic disease. So this is a hyoid bone. This is hyoid bone. This is the median glossoepiglottic fold. We discussed yesterday. This is the vallecula. This is epiglottis, and this is a pharyngoepiglottic fold. You can see a lesion in the right pharyngoepiglottic fold. You can see an enhancing lesion, asymmetry compared to the left side. Okay, I have not taken all the cuts, but this is a lesion there. This is the normal array-epiglottic fold on the left side. Okay, but this on the right side. This is on the right side. You can see an enhancing lesion involving the array-epiglottic fold. Okay, and also the lesion is extending. You can see the array-epiglottic fold, and compared to the left side, there is a minimal obliteration of the right piriform fossa. So this was the lesion, and in this patient, there was no nodes. Okay, so how you should contour this patient is that this is the GTV. So always you should have a proper correlation with your endoscopy and your CT scan before you do a contouring. Okay, so this is your GTV. Then you give another 5 mm. So that is your CTVP1, 70-degree equivalent dose. We use 66 grain 30 fractions, 60 grain 30 fractions, and 54 grain 30 fractions, the simultaneous integrated boost. So this will be 66 gray volume. So this is the GTV. This will be CTVP1. That's 66 grain 30 volume. So you can edit that area from the hyoid bone. You need not, because hyoid bone is a boundary. Sorry, there is a natural barrier is there. Usually the tumors will not spill. So you can see that safely you can limit that to the inner aspect of, or this hyoid bone. Then you give 5 mm margin all around. So CTVP1 is GTV plus 5 mm business. But it may not be the situation. If you look into the international guidelines, which published in 2018, which shows that you can edit from the air, and this can be editing can be done in situations. There is a so you can see that there is some problem with my slide. Okay, so if you edit, you can edit from air. Okay, this is how the international guidelines say that you give 5 mm, then you can edit from the air. But this patient was not treated with after editing. Okay, so this was the CTVP1. Then you give another 5 mm, that's your CTVP2. So you can just edit from the lateral aspect of the hyoid bone. Okay, so this is your CTVP2. Now this is another cut. Okay, this is your GTV. Then you give 5 mm. So you edit from the submandibular gland, the lower limit of submandibular gland. Okay, again a natural barrier. Okay, you give 5 mm margin all around. So that is your CTV66. Then you give another 5 mm. So that is your CTV60. But you can also say that this can be edited. So this can be edited. That's how the CTVP1 will look like. So this is CTVP1 when you edit from the air. So without editing the CTV-P2. So this is GTV, this is CTV-P1, this is CTV-P2, right? Now at the lower limit, this is your GTV. You can see the lesion in the area epiglottic fold, normal area epiglottic fold on left side. There is a minimal obliteration of the right pyriform fossa compared to the left side. Lesion is extending into the just extending into the, you cannot clearly make out whether it is extending into the paraglottic fat. Okay, it's T2 bar T3. Then this is your GTV. You give 5 mm margin. International guidelines say that two things. One, you need not treat the air. Second, you need not take the parapharyngeal if it is not clearly involved. But this may be a peduncle tumor just touching the posterior pharyngeal wall. Okay, there is some problem. Okay, this is a 5 mm. This is again with the editing, the air from the air. But this patient was not treated with editing. So this will be the final CTV P2. This is your GTV. This is your CTV P1. This is your CTV P2. Okay, so that is the final oleum for the primary tumor in this cut. Now the nodes. This node was, the patient was not having any lymph nodes. So we have treated level 2, 3, and 4 electively, 2, 3, and 4 electively, to a dose of a 54 gray in 30 fractions, a 50 gray equivalent dose. Okay, so this is the oleums. You can see that this is a primary tumor, GTV, then you give CTV P1, this is your CTV P2, this is your nodal intermediate risk oleum because there is no high risk oleum because the absent nodes were not there. Okay, so 2, 3, and 4. Which level of lymph node is this? This is the level 2 lymph node. Again, I told you yesterday because this is involving the hyoid bone. Okay, this is correlated with the hyoid bone. That is level 2. The anterior limit of the level 2 is the posterior edge of the submandibular gland. You can see that medially it is the internal carotid artery and also the lateral edge of the scalenus muscle. And posteriorly, it is the posterior edge of the sternocleidomastoid. Medially, it is the, laterally, it is the medial edge of the sternocleidomastoid. And also platysma, you can see that. Higher up, you will see a parotid gland also, and the posterior of the digastric as the lateral boundary of the level 2 lymph node. Okay, so this is a level 2, and this is at the level 3. Why? It is thyroid. You can see thyroid cartilage. So it extends anteriorly, posterior 1/3 of the, this is the thyrohyoid muscle. The posterior 1/3 is part of the level 3. Again, the medial, posterior, and lateral boundaries are same for level 2 and level. So now coming to the distribution, this is the CTV P1 and this is the PTV. This is the GTV. I'm sorry. This is the CTV P1. So this is the CTV P1 on this cut. Okay, this is 66 gray itself was covering. Very recently planned in our new halcyon machine. Okay, so 66 was covering the CTV P1 itself. Okay, so this is the CTV P1 dose. In the CTV P2, so this was a PTV, I'm sorry. This is a PTV. So this is PTV should cover. So the GTV, the criteria should be the 100% of the dose should receive the 100% of the oleum. The 98% of the dose should receive the 100% of the oleum for CTV. And 95% of the dose should receive 100% of the oleum for PTV. That's the acceptance criteria. So this is the PTV of that is a 95%. So this is again covering, this is a 6270, that was the dose for the PTV. Now if the CTV 60 here, and there is no CTV 60 here because only 54 was given, 54 and 30. So this is a 95% of 98% of the 54 gray, that is 5225 if my memory is correct. So this is the distribution. It covers the lymph nodes, and 98% of that is covering that whole node, level 2, level 3. Thank you very much for your patient listening. So I'll be happy to take few questions. Yes. Hello. May I take the case questions now?
Yes, sir. We can have questions now. Some have been entered in chat.
Okay. Yes. In early larynx T1 and T2, few concerns says to include the entire larynx as CTV and plan CTVs. Okay, basically now the concept is slowly fading away. If you look into the 2018 guidelines, you can see that entire larynx need not be treated. Even for T3 disease, a substantial portion of the contralateral area can be treated. There's no need to treat the entire larynx as of now in 2023. But you have to include a 5 mm business. You need to include a pre-epiglottic space and the areas where it is really required, and the ipsilateral paraglottic fat and required. There is no need to treat the contralateral larynx. How to identify apex and the floor of ventricle in CT? It is very difficult. Okay, if you look into the apex of the pyriform fossa is found out. I showed you yesterday how to look for the apex of the pyriform fossa. It's at the level of the true vocal cord. Okay, whereas the ventricle, it is difficult, okay, to make out in the axial view. You have to use a coronal view, and to know whether this the ventricle, you need to know that. Can you please explain how you will plan for hyperfractionation, dose practicing? T1 and T2 disease in our institution, we follow 5 to 52.5 grain, 15 fractions. That's applicable in 2 sites in our institution. One, vocal cord T1 and T2. Buccal mucosa proliferative disease. In Kerala, we come across a lot of proliferative buccal mucosa disease. That may not be the situation in other states because of the aracanut. So they are highly sensitive to radiotherapy. We accepted for publication our data of buccal mucosa with hypofractionation. So we believe that there is a role for hypofraction in early disease. In laryngeal vocal cord, we have shown the results and we are updating the results. In buccal mucosa, we have 517 patient data, and we accepted for publication. Within few weeks, it will be published. And it also shows very good response. Again, we use 52.5 grain 50 fractions. Selected patients, T1, T2, buccal mucosa, proliferative tumor, then no notes, then we will give that dose. That's only for 2 situations. That one is for buccal mucosa, another is for glottic tumor. Yes, Bindu madam has asked. So now, is it necessary to bolus if undercommation is involved when we use VMAT? Okay, that's again, when you use a VMAT, always you look for, it may be the bolus thickness may be a little higher, we may require because we are using 6 mm photon. In our institution, we used to treat all this T1, T2 vocal cord in cobalt. Now our cobalt machine is dysfunctional. We have a synergy where we have 4 mm photon. We are using 4 mm photon, and we take we contour and then we treat them. We usually give 5 mm bolus if it is in, and generally we avoid IMRT for T1 and T2 vocal cord, to be very honest with you. Then if you use in VMAT, definitely for always you look for the O-limb, distribution. If it is covering, that's fine. But usually we require a bolus, that too 1 cm bolus for a 6 mm. How do you treat a patient with cartilage invasion post NACT? Good response, refusing surgery or medically inoperable? That's a very good question. Even I have asked such a question. Even if the patient is fit for surgery, there are some situations where, because we have a waiting period of 4 to 6 weeks, most of this T4 disease with the cartilage destruction will be receiving induction care, to be very honest with you. And if the patient has again, our head and neck surgeon do an endoscopy before admitting the patient for total laryngectomy. If the patient is having a CR, 2 situations. One, CR does not mean pathological response. So ideally, this patient was not a candidate for organ preservation. Patient should undergo a total laryngectomy followed by post-op radiation. But you need to understand that. But if the patient undergo laryngectomy, there is a chance that the final HPR maybe shows only a necrotic tissue. So you have to tie a note in this situation, and always we discuss with the family and patient. Okay, so clinical remission does not mean pathological response. But again, this patient is not a candidate for radical chemoradiation. But even if the patient undergo chemoradiation, there is a patient can have a dysfunction of the larynx. But at the other side, if there is a very good response, then there is no data evaluating this clinical problem. In this group of patients, if you subject them for laryngectomy, there is no disease. Sometimes we get Patient will be seen by us. We will give induction chemo. The patient will be seen by surgeon before starting induction chemo. Then after the induction chemo, the patient will be seen again by the head and neck surgical oncologist. And they say, there's a very good response. Cessal, why don't you give chemo radiation for the patient? Okay, I discuss with the patient, and then we'll take the patient for chemo radiation. If it is medically inoperable, okay, that decision, if the patient is having a comorbidity and all these situations, I ensure that the patient is medically fit for anesthesia fit before giving induction chemotherapy. Otherwise, if there is a very good chemo, we give induction chemo, and if it is medically inoperable, then we will have issues. Then we have negotiated, because we started with surgery as an intention of treatment. Then after induction chemotherapy, if there is a very good response, then how to proceed further, and if it is medically inoperable. Okay, so my personal view is that any patient who has comorbidity, any other issues, ensure that this patient is fit for anesthesia at that juncture. Then you give induction chemotherapy. Okay, that's fine. But after induction chemotherapy, patient may not become, due to some other issues, the patient may not become medically any issue. Unfit can occur, but it may be wise to have the patient to have a anesthesia fit before induction chemotherapy. T4B with cartilage destruction, if not willing for surgery, can we offer chemo radiation? I do not know the answer because there is no data. All this business of whether the patient is willing, that should be negotiated before giving induction chemotherapy. And this also, when I give induction chemotherapy for a T4 larynx, I always say that even if the patient, you may attain a complete clinical response. If the patient may have a very good response, but still you need to undergo surgery. Okay, we do not know whether the chemo radiation is good enough in this group of patients. Okay. A patient T4 with cartilage destruction, if not willing for that, we have taken. Sir, is it safe to go for more than 2.1 Gray larynx to accept pure vocal cord? So some authors are not recommending. Okay, that's a very good question. If you look into the UK protocols, they use 60 Gray in 25 fractions. We also believe that's a good way of handling in patients in institutions have heavy load. We also use 60 Gray in 25 in patients who have supraglottic larynx tumors. But I agree that any fractionation above 2.5 fraction, 2.1, it can have an impact on long-term toxicities. T3 disease with organ dysfunction, should be prefer surgery or chemoradiation, sir? In a patient, if the patient is aspirating in a T3 disease, it may be wise to subject that patient for surgery. Okay, it does not mean that the patient with a tracheostomy should be offered surgery, but any aspiration in fluoroscopy, because even if the patient undergo chemoradiation, the dysfunction will continue. That will lead on to aspiration. The patient may have to undergo salvage laryngectomy because of the dysfunction of the larynx. Sometimes he may not be able to undergo a salvage surgery because of poor pulmonary function. So all these things have to be taken care of before taking the patient for chemoradiation. Now, another prerequisite for considering chemoradiation in larynx is that concurrent chemoradiation will lead on to a CR to the tune of around 80%. In our results, it is same. But you need to be prepared for 10 to 16% to have a residual disease. In this group of patients, there should be a good salvage surgery team to take care of them. Chemoradiation plus salvage surgery is equivalent to total laryngectomy followed by postoperative. So one of the things which should, if there is no proper salvage surgery is done, then survival will be poor in this group of patients. Do we take level 4B? No. In every laryngeal tumors, no. Okay, whether it is 6, no. The patient level 6 should be considered if the patient is having a subglottic extension is present. We need to treat as level 6 lymph nodes. Your thoughts that? Hence, okay. Maybe because yes, because of the glottis, that hence hypo benefit. Okay, even in our institution, hypofraction was a standard 3.5 Gray per fraction. In selected T1 or T2 vocal cord, it was very difficult to accept even for me because giving 3.5 Gray per fraction is very difficult. But we have shown you the results. The long-term toxicity in the series we published recently is 2.1%. It's well tolerated. 52.5 Gray in 15 fractions. Sir, whether the field borders are same in conventional treatment for planning anterior one-third and posterior one-third combination. Yes, and same. You have to consider the borders I mentioned was a conventional treatment. There's the anterior one-third of the vertebra. You go C2, C3 superiorly, lower down C6 vertebra, caudal edge, anteriorly a flash, 6 into 6, 6.5, 6.5. Thank you. I think the whole thing has been taken. It is 6:02 p.m. Can we wind up? Yes, one more question. Good evening, sir. Thank you for the wonderful presentation. See, options for manager recurrent laryngeal primary in already treated patient. That itself is a different topic. Okay. Recurrence bars, recurrence. So if it is a recurrence after radiation or chemoradiation, in a highly selected recurrence in T1 and T2 code, our surgeons had been laser highly selected. Otherwise, you have to, in advanced disease, after supraglottic tumor or after chemoradiation for a T3 disease, standard treatment is to do a salvage laryngectomy. Okay. Then recurrent, again, you have to consider the all factors, different factors to be taken care of. What is the performance status? What is the age of the patient? What is the disease-free interval? Whether the patient has received chemoradiation adequately? What is the expectation of the patient? Then what is the function of the larynx at the moment? All these factors we need to take into consideration. Was laryngeal edema seen in case treated with 52.5? That's a very good question. They are well tolerated. I've seen it more with patients. Thank you. Shall we wind up?
Thank you, sir. Thank you on behalf of our department, RCC Jitmer. I take this opportunity to thank you, sir, for taking your precious time to be with us today. And this was really a wonderful session with a lot of live cases. You discussed more of a case-based thing, rather than just presentation. And the questionnaire session is also great. It was a great insightful session. Our residents and faculty are privileged to participate in this seminar. I also thank our faculty, chief resident, and students for conducting this seminar. Thank you, sir. And we hope to have many more similar opportunities in the future. Thank you very much, sir, for this time.
Thank you.
Manaval, shall we conclude it?
Yes, sir. We can conclude the session. And once again, thank you, sir.
Thank you, sir. Thank you very much.